So we are coming to the end of AIOS APAO 2025, and this is the last session of the Mammoth Conference. All of us enjoyed the 4 days, and I thank AIOS for giving us one session representing KSOS. So we have a potpourri of pearls from my challenging case. Most of us are having some challenging cases, and we will discuss. As the previous session they were mentioning, this is all recorded. You can watch it later also, even if there are not many audience here. So first I will invite Dr. Minu Mathan, the most sought after speaker in AIOS. So this is his last session, last talk in this whole conference.
Thank you, Mahesh, President KSOS, and dear friends. Thanks to AIOS for this opportunity. And my presentation is on different techniques on phaco in different grades of posterior polar cataract. So generally we get soft cases like this. So femtophaco is a very good tool if you have access, because the rhexis is done for sure. So rhexis is very important. If you have the PC opening up, then we can place the lens on the rhexis, and if it is centered well and sized properly like in a femto case, you can always capture the lens also. And doing nucleotomy in a cylindrical fashion, that is very useful in this femto phaco, so that you can aspirate off the center without any hydrodissection. The nucleus comes off. So no hydro procedure is required. We just have to go in a spiral fashion and aspirate the pre-cut nucleus in the center. So towards the after that, there is thick epinucleus remaining. So either it can be mechanically separated using a blunt tip chopper, or it can be visco-dissected and then gradually pulled from equator all the sides. See, now I can see that the polar cataract is off and there is no PC rupture. So then I can proceed, but then always have it in mind that it's a very weak area and a thin area, and it should not be handled roughly like a regular posterior capsule. Be very careful and gentle with the central part of the posterior capsule in all posterior polar cataracts. And once that is done, do not shallow the chamber. It's very crucial. Place viscoelastic before you remove your handpiece, and then cortex aspiration again from the equator first, and finish off the equatorial part and come to the center, because during IA, if the PC opens, most of the peripheral cortex is aspirated if you come to the central part at the end, and an IOL can be placed into the bag. And also at the end, hydration, it should be done gently and carefully. Do not hyperinflate. This is a posterior polar with an open PC. You can see the end-to-end opening of the posterior capsule. So sizing and centration of the rhexis is very, very important. 5 millimeter or less than that. I am doing no hydro procedure. This is my 2 millimeter long blunt tip chopper, and this is the technique which I follow now in all the cases. I go spirally around the nucleus. This is called the coring technique. I go around the nucleus. The epinucleus is taken out with minimal vacuum and adequate energy to take out the nucleus, and the bent Kelman tip is enough for this. I have realized you don't need a special tip for that. So when the red glow brightens, it means that you have gone deep enough, and then if you can easily pick up the nucleus from the center. And now you have the thick epinucleus left. See the manual separation of the epinucleus from close to the equator. This is using the 2 millimeter long blunt tip chopper, and then one area which is opposite to your incision can be freed once, and once the equator is freed in one area, there is more space and room, and we can continue using this for the temporal 180 degrees, and after that you can replace viscoelastic in the anterior chamber before removing, if you want to remove. But then I am continuing without doing that. The second instrument can be taken out. This is picking out the epinucleus out. There is no rotation happening. This is going towards the equator and picking it up from different directions. If it is difficult for a surgeon, you can stop, put in viscoelastic, go in through another paracentesis and mechanically remove the nucleus from different angles. But the two paracentesis on both sides and the main incision will be enough to mobilize the whole of it. And luckily the PC rent has not extended, and always put in viscoelastic before exchanging instruments. And aspiration rate has to be very low. That is very, very important. In IA also, if you have aspiration rate very high, you can pull on to the vitreous which is not yet disturbed, the anterivitreous phase, and cortex can be aspirated while exchanging hands also. Please do fill in viscoelastic like this, and then take out the irrigation and aspirate from the equator, bring it up and bring it into an area where there is no, the PC is intact, and aspirate very gently. Use the irrigation, very important, should not be facing the open PC. It should be facing the equator, the angle, or above the iris plane, so that there is no turbulence into the open posterior capsule area. Once that is finished, we can again put in sodium hyaluronate for IOL placement, because there is no extension onto the side, because it is like a two pillars, you can see this. So in posterior polar it's like that. So if we open up the bag and there is no vitreous disturbance, you can always place a single piece lens into the bag. But nowadays I prefer 3-piece lenses in the sulcus, and the central sized rexus can always be used to capture the IOL into the capsular rexus margin. Be very gentle in placing this. Once you have a capsule rexus tear, then it is difficult to place even these lenses. So please be careful about injecting 3-piece lenses, the multi-piece lenses, and aspirate as much as possible by irrigating from behind the IOL. Don't go too much underneath the IOL. You can always leave a little bit of sodium hyaluronate behind. It doesn't cause IOP rise or inflammation. And at the end, you can try to capture the optic in the rexus margin if your sizing is right. If it is too big, you can leave it in the sulcus also, doesn't matter. So this is how, after the capture, optic capture, these two haptics are out. So this is the third one where the nucleus is hard with the posterior polar cataract. So here there is no hydrodissection done. The central debulking of the nucleus is done, and the chopping is done towards my left. Here it's a sharp tip chopper which is being used, and towards my right one more chop. So you get 1 pi, which is almost 1/8 of the nucleus, and that can be removed. Once that is removed, you turn the tip towards the left and make 1 more pi. So again 20% of the nucleus comes out. Then turn towards the right, and then make 1 more chop. So this is the way you can disassemble a nucleus which is hard without any nucleus rotation. So now I take out my chopper and bring in the other side of my chopper, which is blunt tipped. So that is moved across along the equator, and then I create a cross chop and support the nucleus with the phaco probe and chop again. And you create another pass along the equator and support it like this and lift up. Now half of the bag is empty. There is a lot of space, and this lens can be picked up from the bag and lifted. There is no rotation. It is just picking up and freeing the nucleus from the bag and lifting out. So this is just a lift out rather than rotate. The shearing force of rotation of the nucleus epinucleus complex is that which causes the even unopened posterior capsule to open up, because you shear out the posterior capsule which is weak, and then this nucleus is brought into the pupillary area and is emulsified completely. Now you can notice, after the nucleus is gone, the central thick posterior polar cataract is still there. This is called viscodissection. So we can go to the equator, decompress the anterior chamber a little bit, and then we inject visco at the equator. So we create potential space between the equatorial epinucleus and the capsular bag, and you can additionally use your blunt tip chopper to mechanically move the epinucleus from the different areas of the equator and then move it free. So go to the equator and start aspirating, and by some time you will realize that the polar cataract has come off and there is no opening. And if there is an opening, we know how to deal with it like I did in the previous case. So the epinucleus is gradually taken out with the phaco probe. Once the epinucleus is gone, change over to IA and then very slowly aspirate. It will take some time because they are thicker epinucleus bits, and then don't irrigate on the center of the posterior capsule. So this is a classical posterior polar cataract, and then we managed to take out the whole thing without an opening. But then the plaque which is there on the posterior capsule is very thick. It is difficult to leave it like that, and patient vision may not be that very great. If we can try to peel it off, but almost never it comes off, and it will come off only with the posterior capsule. It will be adherent to that. So we can, like we do in pediatric cataracts, we can do a posterior capsule rexus here, identify one area where you have lifted it up, and then turn your tip towards the side and then hold it and include the central area. And I'm trying to peel it off, it doesn't happen. So make a small nick somewhere wherever you can, and then include this one also. So I have made a nick here, and then including this plaque, we can do a central posterior capsule rexus. And then this, if you put in sodium hyaluronate, little bit of sodium hyaluronate in the anterior vitreous face, you will be able to catch only the capsule and do a clean central 3 millimeter opening so that you can place the IOL, single piece IOL into the bag itself. I now am always for 3-piece IOLs. If I don't promise for this post-polar cataract toric IOLs or multifocal IOLs, because anytime anything can happen, so no promise of any premium IOL. So I go into the sulcus and then capture it, and it's a very stable positioning of 3-piece IOL into the sulcus and capturing it into the rexus margin. And aspirating behind it is not that very easy to avoid vitreous prolapse. You will get vitreous. So if you want to take off all the visco which has gone behind, you can always do a little bit of vitrectomy along with aspirating. You can complete. Now I'm going with the vitrector and completing the aspiration of the visco along with the anti-vitreous phase, and maintain irrigation. Now with the irrigating aspirating probe, we can gently tap the margin of the equator underneath the rexus margin so that it is captured very well and the lens is very much centered. It's because many times the sulcus is different in size. In some location the 3-piece lens will be more centered, some location will be decentered little bit. So it is always good to capture in a rexus margin whenever you put a lens into the sulcus. And thank you very much.
Thank you, Minu.
Any comments?
Yeah. Just one doubt regarding the last video. Is it always advisable to do the posterior capsular rexus? We can do a eye capsulotomy later also.
Yes, that is very much possible. Only thing is, when it is so thick that post-operatively also vision is going to be very low and patient is not going to accept, and if you want. So always it's up to the convenience and the expertise of the surgeon. If you feel that you're going to damage more, you're not able to get a posterior capsular rexus, you won't be able to place the IOL properly, don't do. You can always tell the patient, because nowadays for other non-posterior polar cataracts also, I am telling patients, showing the picture that the posterior plaque is thick and it may be extending onto your posterior capsule, and vision may not be complete, it may be subnormal. You will need a yak capsule later. This cannot be taken out during phaco. I tell all thick posterior subcapsular cataracts also.
Some of the silicone oil related cataract also, they have this plaque, no, in the posterior pole.
Posterior pole.
Sometimes they
But
may
many
be able
of
to
them
peel.
come off very easily. Many of them
peel.
can be peeled off. If you slowly try to, with a blunt dissection, if you try to identify the plane, it will come off. But some are behind the posterior capsule.
Yes.
Some are behind the posterior capsule. It will never happen. We'll have to cut it with. But I place the lens and ask them to cut it with the vitrector and take it off. So that's what happens with silicone oil. So always the VR people will cut it off with this with the vitrector and clear that off.
Thank you, Minu.
Thank you. Thank you, Minu. Next we call upon Dr. Elizabeth Joseph. She will be talking about great challenge and innovative correction of lateral rectus palsy by silicone band sling procedure. Dr. Elizabeth is one of the senior most consultants in pediatric ophthalmology in India and Vice President of Strabismological Society of India. Over to you, ma'am.
Good morning and welcome everyone. First of all, I would like to thank the President of KSOS, Dr. Mahesh, and Scientific Committee Chairman, Dr. Bastin, for giving me this opportunity. I'll be discussing about silicone band belting of the vertical recti in lateral rectus palsy. See, this is one of my challenging cases. This lady had an intracranial tumor. The surgery was done, and because of the intracranial tumor, she developed right lateral rectus palsy. And in a few months' time, the medial rectus got contractured, and she developed a large esotropia of 80 prism diopters with medial rectus contracture and absence of abduction. You can see that the patient is looking towards the left side. The left eye is abducting fully. The right eye is adducting beyond normal. And when the patient is looking towards the right side, the left eye is fully adducted, but the right eye is not coming even up to the midline. So there is a huge medial rectus contracture with the total paralysis of the lateral rectus palsy. what are the surgical options we have right now? Right now, the most popular options is to do a large medial rectus recession of about 12 or 14 millimeters. If you do a large medial rectus recession of 12 or 14 millimeters, probably you can make the eye straight, but there will be absence of adduction too. So you will produce absence of adduction also if you do a large medial rectus recession. And then this large medial rectus recession can be combined with vertical rectus transposition to lateral rectus, either full tendon transposition or partial transposition. This the latest is Nishida's transposition. But all these procedures have got limited success in such a large esotropia. And if you combine more than 3 rectus muscle surgery at one shot, there is a risk of anterior segment ischemia, which will lead to loss of vision of that patient. So that is a huge risk involved in such a old patient. So I thought, what else could be done? And then search the literature. There is just one report of medial silicone band belting of the superior rectus and inferior rectus. They used that's one report in British Medical Journal, and they used a 240 retinal band, 2.5 millimeters encircling band to belt the superior rectus and inferior rectus. Placing a silicone band around the lateral halves of superior rectus and inferior rectus to change the force vector. The silicone tube will act as a sling to maintain alignment in the primary position, and the band will stretch on contraction of the antagonist muscle, and on relaxation of the antagonist, the band would move the eye back to the resting position, allowing some ocular rotation and changing the vector of the muscle forces. See, silicone bands have been used in strabismus surgery for several years, and this is very useful in myopic strabismus fixes where you band the superior rectus and lateral rectus. In Brown syndrome, we use the silicone band as a superior oblique tendon sheath expansion technique. And so we strabismologists have got a good experience in using these silicone bands, and nowadays very rarely some strabismologists have started using it in Ella palsy. See, this is the surgical. I am doing a force duction test. You can see that the eye cannot be moved medially, and I have done a moderate medial rectus recession of about 6 millimeters so that the adduction will be maintained. Then through superotemporal and infratemporal fornix incision, we expose now the superior rectus muscle is exposed, and then the superior rectus is split into two, the medial and lateral halves. And you have to split the muscle as back as possible, namely about 14 millimeters behind, so that the lateral part of the superior rectus can be brought laterally. And then the silicone band is passed underneath the lateral half of the superior rectus muscle. And then the silicone band is passed underneath the you rotate. You can see that the muscle is being pulled. Make sure that it can be pulled now, enough. And now I have passed it underneath the lateral rectus. Now you can see the band under the lateral rectus, and then I am trying to pass it through the lateral half of the inferior rectus. So the silicone band involving lateral half of the superior rectus and inferior rectus passed underneath the lateral rectus. The lateral rectus muscle will act as a force to keep the muscle in keep the sling in position. And then this is sutured with the non-absorbable sutures. After putting the suture, you examine see whether the eye has come to the primary position. If the eye has rotated to the primary position, then that is the tension on the silicone band, that is good enough. And you can put multiple sutures to keep the silicone band in position. Actually, the sling passed underneath the lateral rectus, the sling will not go posterior, because when it moves posteriorly, the equator will has got a larger diameter, so it cannot go posteriorly, and also it will not move anteriorly because medial rectus insertion will keep it there. But even then, if you feel that the muscle sling has to be fixed, you can have additional sutures to fix the sling to the sclera if needed. And after this, make sure that the eye has come to the primary position. and then you can close the conjunctiva. You can do a repeat force reduction test and make sure that eye can be moved in the adducted and abducted position. And look at the preoperative picture, huge esotropia with the absence of abduction, total absence -5 abduction. Look at the post-op picture. It was a very rewarding. I have limited my surgery to one eye only. I didn't touch the other eye. See the amount of abduction I got, some about there is limitation of -3 abduction, and vertical movements are okay. So this patient, I have a long-term follow-up of up to 3 years. There is a stable alignment. There is no extrusion of the band, and getting confidence from that one case. Another patient who had a traumatic lateral rectus palsy, but that was not so huge, of the this eye, left eye, with absence of abduction. This patient also I tried recently, and I could make a good result. You can see that immediate postoperatively there is some congestion. If you look carefully, there is some amount of bulging there because of the inflammation in 1 month's time. There's some amount of inflammation there, so you can see a little bit of bulging, which I noticed, but the patient didn't complain. So literature review. Vertical muscle transposition using silicon band described in 2016, one article in BMJ, and American Journal also one article, that's all. And coming to the advantages of this procedure, the tension on the silicon band can be adjusted intraoperatively, as it can be tightened or loosened as required to bring the eye to the primary position. There is no need of tenectomy or muscle disinsertion, so less chance of anterior segment ischemia. This will retain all the advantages of vertical muscle transposition, but this is better than other transposition procedures with medial rectus contracture and -5 abduction deficit, because the silicon band will support the tension of the transposed muscles, unlike direct muscle suture to the sclera. Again, this is a reversible procedure and can be removed or readjusted if overcorrection. Thank you very much, KSYs and the AIOS.
Thank you, madam. This that 240 band only you're use, no? It's not available nowadays.
It's available in our OT because
we are
the
finding
scleral
short
bands
supply.
they use for children for retinal detachment.
No, that thing is not available for retina surgery now.
What?
Now whatever you have, you use and finish. Yeah. Nice.
Yeah, primary position diplopia is not there, but when the patient abducts, there will be double vision. But previously, there is double vision even in primary position.
Can it actually, some of our old buckles, this buckle can intrude cut through the muscle and come out. So I don't know.
Yeah, I have a 3 years follow up now.
Yeah.
It has not extruded.
Yeah. Some 2000 case and all coming now with buckle in front of the muscle. Muscle intact. It cut through and then I don't know how it comes. Migration. It's called anterior migration of the buckle.
Probably it is too tight, maybe.
Thank you, madam.
The next speaker is Dr. David Puthukadan. He'll be speaking about custom graft in perforated PUK. Over to you, Dr. David.
Can you change the slide? Presentation is not come. Good afternoon, everyone. I'll be presenting a challenging case of perforated PUK, which we may manage with a custom graft. So, PUK or peripheral ulcerative keratitis is a destructive inflammatory disease of the juxtalimbal corneal stroma that is associated with an epithelial defect, the presence of inflammatory cells in the stroma, and progressive stromal melting. The causes described include infectious causes like herpes simplex virus infection, local causes like chemical injury, local non-inflammatory causes like neurotrophic ulcer, degenerative diseases like Terrien's marginal degeneration. Local inflammatory causes include Moran's ulcer, and systemic causes, which are the main one, which include connective tissue diseases like rheumatoid arthritis. And systemic non-inflammatory causes include nutritional deficiency and malignancy. Surgical interventions are indicated when there is severe thinning, there is an impending perforation, or when there is a large perforation. The surgical modalities described include amniotic membrane grafting with fibrin glue, synaculate glue application, conjunctival resection with or without cryotherapy, and a keratoplasty. The corneal transplantation may be in the form of a lamellar keratoplasty when there is a large area of severe thinning and there is an impending perforation. Full thickness graft may be performed when there is extensive PUK and there is a large perforation. Custom graft may be performed when the involvement is only in a small area, when it is limited to 2 or 3 clock hours, and the custom graft may be in the form of a crescentic or a C-shaped graft. Coming to our case, our patient was a 58-year-old male who presented with history of pain, watering and redness in both eyes, approximately 2 months duration. He had a decreased vision and increased pain in the left eye over the past 1 week. The only relevant history was a joint pain involving the metacarpophalangeal joints, for which he didn't take any medication. This was a picture on presentation. The right eye best corrected visual acuity was 6/6 parts, and on slit lamp examination there was extensive infiltration of the peripheral stroma extending from 3 o'clock to 9 o'clock position with approximate 80% thinning. In the left eye, the best corrected visual acuity was 3/60. There was PUK extending from 4 o'clock to 11 o'clock position with a perforation between 7 to 8 o'clock position. The perforation was approximately 4×2 mm with extensive iris prolapse. There was peaking of the pupil, a shallow anterior chamber, and cataractous changes in the lens. We consulted a rheumatologist, and as per his advice, we performed the basic investigations, of which the only positive ones were a mild elevated ESR and a C-reactive protein. So with this help, we reached a diagnosis of autoimmune disease of unclassified etiology because ESR, CRP was elevated and there was history of joint pain. And treatment was started. The treatment included injection methotrexate 25 mg subcutaneous weekly and prednisolone 60 mg daily, along with folic acid, omeprazole, and doxycycline. Topical treatment included prednisolone acetate drops, lubricants, and antibiotics. The surgical treatment planned included right eye conjunctival resection and the left eye conjunctival resection with crescentic patch graft after abscising the prolapsed iris was performed. Coming to the surgical video, the first step was to perform a conjunctival resection. Conjunctival resection was performed beyond the area of infiltration. Conjunctival resection will help in preventing the inflammatory mediators from reaching the area of infiltration. Another advantage is that it will facilitate easy suturing because the scleral tissue, when you are putting the sutures at the scleral tissue, if there is conjunctiva, the sutures, there is a chance of it passing through the scleral tissue. So the conjunctival resection is completed and bleeders are cauterized. This is followed by using of calipers to measure the area of trephination. So you need a crescentic bed, host corneal bed to suture the donor cornea. So the cornea is marked with the help of blunt trephines. Trephination cannot be employed to full extent because it is just for marking. It's a perforated corneal ulcer. So if you do a severe trephination, that will cause further perforation and iris and other prolapse. So a crescent-shaped host corneal bed is prepared. The prolapsed iris, which is non-viable, is excised so as to form a peripheral iridectomy. Coming to donor corneal trephination, the donor cornea is trephined to form a crescentic patch graft. So the outer area of the crescentic patch graft is made with the help of a large 12 mm trephine. the size of the host or width of the host corneal bed is measured and that is replicated on the donor cornea. A decentered trephination is employed to form a crescent-shaped patch graft. Coming to suturing of the patch graft, the outer sutures are first placed so as to anchor the graft to the host corneal bed. Once the outer sutures are secured, the inner sutures are placed. The inner sutures are placed such a way that a radial alignment is maintained as far as possible. This will reduce, there will be some amount of astigmatism, but this will help in reducing the extent of astigmatism. Here you can see that there is some amount of excess tissue. So this excess tissue is trimmed so that the graft would snugly fit into the host corneal bed. The suturing is completed so as to form a watertight anterior chamber. The knots are buried so that the irritation will be less and the chance of vascularization also will be reduced. Okay. Coming to the outcomes, this was a picture of the right eye on presentation. At 1 week, you can see that the infiltration has come down with conjunctival resection. Some amount of infiltration is still persisting. At 2 months, you can see that there is some amount of scarring and thinning is there. Epithelialization has occurred. And at 1 year, you can see that the best corrected visual acuity of 6/6 parts is retained. There is some amount of scarring and severe thinning. And coming to the left eye, this was a picture on presentation. At 1 week, you can see that the graft has started clearing. AC is well formed. There is a peripheral iodectomy and pupil is round. At 2 months, the graft has cleared further. Sutures are intact and AC is well formed. But this was not the same at 1 year. The graft had failed. There was some amount of peripheral anterior synechiae. The sutures had become loose. But you can see that the central area clarity is still maintained. There was a mature cataract and patient is awaiting a cataract surgery. So our outcomes were very much comparable with the other studies. The common complications which were listed include vascular ingrowth, persistent epithelial defect, graft melt, and early loosening of the sutures. We had a failed graft, but the graft was successful in maintaining the anatomical integrity, and there is always a potential for visual rehabilitation remaining. So to conclude, perforation in PUK is an ophthalmic emergency. A timely systemic evaluation with a rheumatologic support is necessary. Parenteral or oral steroids are the mainstay of treatment along with topical steroids. A timely surgical intervention will help in maintaining the providing the tectonic support and for visual rehabilitation. Thank you.
Thank you. David, any comments? Vinay, any?
IOP was maintained because there was peripheral anterior synechiae only in 2 or 3 two quadrants. The other area was clear and AC was well formed. There was no IOP. The vision was less because of the cataract and there was some amount of astigmatism. Okay, reading could not be recorded properly because it was close to the central area.
Any comments?
There was 80% thinning. I think with topical steroids and oral steroids, it was responding. And we planned a conjunctival resection only. So we'll go in the sense the fibrin synovial.
Usually it is said that it is the conjunctival resection does help in reducing the
Inflammatory.
of all the
Inflammatory mediators.
The glue has, in addition to tectonic support, augments this. It provides a physical barrier for the mediators from the tears and the surrounding blood get access to the pituitary colony. So it is said that along with resection, it is always better to do
Yes, right.
PCL also. Another important message here is, managing the eye is just one part here. That is not the most important thing in these cases.
Immunological support is the main thing.
Systemic problem is the most important aspect.
Actually, the rheumatologist had advice for biologicals, but patient was not. It was not affordable for the patient. That's why he had to resort to methotrexate alone.
Thank you, Dr. David, for that nice talk. We'll go to the glaucoma talk by Dr. Thomas George. He is one of the popular speakers from Kerala, senior glaucoma consultant in Chaitanya.
Thank you. Thank you, Mahesh and Bastion. Good afternoon, everybody. Though I talk about three scenarios, it is not restricted to glaucoma. It can happen in any intraocular surgery. And the first one, I was going for a glaucoma triple, that's a cataract plus strap. Did a paracentesis, but the visco came a little late, is what I remembered that time. Phaco went off fine, and this is what the situation was. Once the visco was out after the lens was removed, the AC kept on shallowing, the lens kept on tilting, and I tried to put an air, and the air comes off, and the globe is very soft actually. So I knew what was going on, so I went on and did a sclerotomy to drain the choroidals. Once that was done, the anterior chamber formed and stayed formed. You can see that the bubble is not flattening out anymore. So when you have a uniformly shallow AC with low IOP, consider a choroidal effusion as a possibility, and when it happens per op, you obviously need to drain it before you can actually proceed further, because that you need the space in the anterior chamber. The next one I'm going through is a 50-year-old diagnosed as an angle closure, and it was on multiple drugs, including Pylo, going to multiple centers, had PI both eyes, but actually the PIs were not patent when it reached us again. There were multiple areas which was tried. Intraocular pressure was 40 in the left eye. I added mannitol and completed the PI and took the patient for TRAB a couple of days later. Even then, the pre-op IOP was 30. Pre-op mannitol was given and controlled paracentesis and proceeded to surgery. Everything was routine till the PI was done. And after the PI was done, I thought I'll try to reform the AC a little bit, and this is what happened. Out comes the anterior vitreous phase, and in panic, I did what I would not have probably done before. If I thought about it a little bit, I actually reposited the vitreous, and mind you, that was quite a tough anterior vitreous phase. It didn't burst open at all, which I was surprised by. Reposited the vitreous, sutured that trap temporarily, and went ahead and decided to go for a Chandler's procedure. When it's an emergency, you have to do something on your own, so you do, but otherwise, if you have the time to think and plan to post the patient with this situation, you would probably want to do get a vitreoretinal surgeon to do a core vitrectomy. That would be preferable with less complications. Anyway, do the sclerotomy like before. I'm just going through the stepwise because peritomy, cauteries, 3.5 millimeters from the limbus, centered radial sclerotomy, because the procedure for the previous sclerotomy is also the same, and cauterize to keep it a little open. This is the only occasion we cauterize to cook this sclera literally, because you want to shrink it a little bit. And I checked for choroidals, it was not there. Unlike the previous case, the globe is not deforming, it's hard and tight, and it's not forming either. So I go on to violate Mahesh's halo space. 12.5 millimeters measured. I put a guard in the form of an artery clamp, so I can't go further. And watch it as nearly the guard reaches there, you will see a gush of fluid there. That's all that was required to decompress. That's fluid behind the posterior vitreous phase is what I believe it is, or rather what we all glaucoma people believe it is. And now you can see the globe deforming, the IOP has come down, it forms easily. I could continue and do the rest of the surgery, but mind you, uniformly shallow AC, high pressure, consider malignant glaucoma as a possibility, and you may, these are procedures you may end up doing it. So you should be familiar, you should have worked it out in your mind, so that when the time comes, you will be able to do it. The third case is again a glaucoma triple I was attempting on an elderly lady well into her 80s, brown cataract, so I needed more time for the cataract part of it. And the AC shallowed during the cataract part of the surgery, and the IOP again was a little on the higher side. And soon I had a PC rent. So when you have a PC rent, you start doing vitrectomy. Concentrate on top of the video. I noticed it a little late, but on the video you can see it brown, and that's the ora serrata, which none of us usually see, but the retinal surgeons regularly see. And once I notice ora serrata, out come the iris hooks. I'm trying to get rid of everything, but it's just walking across a pupil. The idea here is emergency management. First aid only is done at this point in time. That is, close up the wound that is able to leak. That's the main wound. And here there is no cosmesis, no thinking about astigmatism, central box suture and continuous running suture with counter sutures is what I use. If you want to say technically, basically somehow suture it and close it. Actually, once the box sutures came into the picture, the movement of the ora serrata stopped. But that is not enough for us to feel secure, so I go on to close the entire wound with a continuous suture. Out here, if any retinal tissue comes out or the blood actually breaches and gets out, your prognosis gets very, very bad. So you're trying to stop it as much as possible, dampen at the bleed. That's the intention at the primary setting. And having something like this is not good for the heart, especially of the surgeon. It's panic. I don't usually shiver when I operate. You can see how I suture. Trembling fingers, all that's there, fine. Anyway, over the next few days to weeks, the hemorrhage just absorbed, so we did not have to actually drain it, but we needed a PPV procedure. I got Manoj to help me with that, and Dr. Manoj is our vitreoretinal surgeon in Chaitanya, and an IOL was placed, vision was good, but 1 month later, traction at the vitreous base did what it always does, a GRT on the opposite side, a repeat procedure, vitrectomy procedure had to be done, and the final vision was 6/9, IOP controlled. So shallow AC, high pressure, change in red glow, expulsive is what you look for. Thank you.
Thank you, Thomas. This first case you drained suprachoroidal, serous choroidal detachment. In the second case it was anterior vitreous, that liquid anterior vitreous that came out.
Not liquid, it's posterior misdirection.
Misdirection.
3 months of pilocarpine
What is
on
that
acute
instrument, that
closure.
long one? What is
MVR,
that?
MVR.
MVR knife only.
But then you,
But that one you have gone through 4 millimeter only, no? That same area.
3.5.
3.5. That's not that. The one thing I was just thinking is, if you do an indirect and see in which area the choroidals are there, that area you can drain. That is a very easy. When we see there is a choroidal detachment, we see okay, temporarily there is a CD, then we go. So this thing will help so that you don't.
The thing is, when retinal surgeons drain, they put one trocar in a tiny thingy. Not like this, where I can put a cyclodialysis in. We work on space. Thank you.
Yeah. Thank you, Dr. Thomas.
The next speaker is Dr. Mahesh. He will be speaking about pearls in the management of submacular hemorrhage. Dr. Mahesh is the president of KSOS, the Kerala Society of Ophthalmic Surgeons, and very senior retinal surgeon at Giridhar Eye Hospital, Kochi. Over to you, Dr. Mahesh.
Thank you, Bastin and KSOS, for this session. I will talk a few points on the management of submacular hemorrhage. Submacular hemorrhage, there are two types. One is subretinal, under the retina, and one is sub-RPE, under the retinal pigment epithelium. So both has implications, and there are different types of classification, small ones, medium ones, large ones, like that. And the natural history of submacular hemorrhage is always poor, because the iron in the blood is toxic to the photoreceptors. There will be shearing, there will be fibrin will be there, which will cause destruction of the RP and photoreceptors. So natural history is always poor. So once it bleeds, it has to be removed. So the damage to macula has to be avoided as early as possible. There are different types of management. One is called anti-VEGF alone. Lot of us do that. For example, small submacular hemorrhage that need not be displaced. You can just inject anti-VEGF, and already you can see some altered dehemoglobinized blood. So these cases you can just give anti-VEGF, because there is no role for displacement from the macula. It's a small one. So follow-up vision after 2 doses of anti-VEGF injection, it has it improved. The OCT has significant improvement. The infrared is showing some hyperreflectivity. So this patient improved to 612. There is another group where the blood is above the fovea or below the fovea, but it has to be treated. So here also you don't need to displace the blood, because if you put gas, it will go under the fovea. So there also we give anti-VEGF injections, and with injection gradually, with 2 or 3 monthly injections, it goes. Number 3, where we do just anti-VEGF, is peripheral, PEHCR, peripheral exudative hemorrhagic choroidal. This is a type of polypoidal choroidal vasculopathy, where you can get peripheral bleeds. Macula is not involved, so you don't have to displace the blood. Just inject, and gradually the right side photo shows patient has stabilized over time with a couple of injections. Number 4, already scarred CNVM or dehemoglobinized blood, you can just inject some anti-VEGF injection. So these are some of the post-injection. This is a picture, even though vision was not good. So this is another case, PEHCR, where there is a peripheral large hemorrhagic choroidal detachment. Here also we give anti-VEGF injections, and it improves. Now this is Paginax is brolucizumab, which has a smaller molecule and penetrates deeper into the subretinal area, which has slightly better advantage. Now the choice of the treatment, like I said, depends on duration, size, thickness, and economics. So we published in 2003 just gas injection for displacement of submacular hemorrhage in IGO in 2003. This was at that time TPA was not available, and later in 2007 we had one big series which was published in Retina, which is even now quoted in many articles. So we had a series of cases where just gas injection was given to displace the blood. These are some of the old pictures where we have displaced the blood with gas injection, and they all did quite well. And this is the pictures from that article. Advantage is very economical. You need only gas. Very effective. Adverse events are less. Drawbacks are there. Need recent hemorrhage, fresh hemorrhage, thick hemorrhage. Pre-retinal sub-RP hemorrhages are not very good, and many of them result in breakthrough vitreous hemorrhage, needing vitrectomy following that. Now came the tissue plasminogen activator. It was quite expensive once upon a time, but now it is available freely with smaller content, and price is also less. So TPA is a drug used to liquefy the blood, and the standard of care now in a large submacular hemorrhage is intravitreal or subretinal TPA with gas. The rationale is this combination helps to liquefy the blood, and gas helps to displace the blood. So this is a case where there is a massive submacular hemorrhage, and this is the OCT. TPA intravitreal was given 50 microgram, followed by gas injection, and immediate post-op day 1 itself it has started displacing. This is another case in the macula and above, and this case had a intravitreal TPA with gas, and following that the blood displaced, improving the vision to 6/9. That is not over. You have to do an ICG or angiogram, then see the polyp you can see in the upper arcade area, and thermal laser was given. But this is not the case for every, this is not the option for every case. Like this, if the large subretinal hemorrhage is there, like this, the only thing is surgery. So surgery is the last choice in many of these cases. And this was a case that I did just 2 weeks back. Massive subretinal hemorrhage and with breakthrough vitreous hemorrhage. So what we do is induce retinal detachment. This was mostly liquefied blood, so it is coming very nicely with suction. So then inject little fluid under the retina, and then again dissolve the, displace the blood. I made 2 retinotomy, and through that injected fluid, and then 3-4 times this was repeated. Finally, the whole this is again inducing retinal detachment. So if the blood is thick, you can inject TPA like this under the retina, wait for some time, liquefy the blood, and remove. Same procedure can be done. So after complete evacuation, as much as possible, silicone oil I put because I am firm believer of silicone oil, and laser was done around the retinotomies. So this is immediate post-op. After 1 week, that massive hemorrhage has gone, and in fact the source of hemorrhage was, there is a large RP rip below infratemporally, so that is the source. So take home messages are small submacular hemorrhage, anti-VEGF, and preferably one of these new generation brolucizumab or something, if that is enough. Fresh subretinal, subretinal, I am again telling sub, not sub RP. TPA with gas is a standard. In cases where TPA is not available, do gas alone with displacement. Massive subretinal hemorrhage, vitrectomy with or without subretinal TPA. So this is a standard of care in managing the subretinal hemorrhage. Why we do all these things? Because if you don't do this, is a standard endpoint with a scar and hand counting finger eccentric vision. Thank you.
Thank you, Mahesh, for that excellent presentation. Any questions?
Immediate. That was the old, the subretinal hemorrhage, it comes, you have to treat immediately, as early as possible.
Will you have to repeat the injections, anti-VEGF?
Anti-VEGF injection, like the first few cases, only anti-VEGF was given, that you have to repeat monthly only, not beyond, not earlier. So that is only a small group. But nowadays you don't wait if there is a large submacular hemorrhage. Immediately do one of these. Lot of people inject TPA subretinally and just put gas. That is also another option. They don't remove completely, then to displace. There is a subretinal cannula is there, 41 months.
Okay, next
I
we
think,
have.
Ramesh has experience in. You have done in a lot of cases there. This anti-VEGF. A lot of cases are there. Yeah. This that in those cases we do fluorescent ICG angiogram and see some polyps are there. We treat that with the so it's a combination. Yeah, some people do come back with new polyps and BVN from different areas. Thank you.
So next we have Dr. Anis Sridhar, senior oculoplastic surgeon from Little Flower Hospital, Angamari. Dr. Annie will be speaking about navigating the challenge of CSF leak in surgical management of optic nerve glioma in a child. Over to you, madam.
So this was my most challenging case I had last year. So this is a 4-year-old boy who came with protrusion since 1 year, and the eye was practically outside the globe, and there were no systemic features like alveoli spots or anything of neurofibromatosis. So this was supposed to be the last slide. Okay. So ocular examination, the perception of light was negative. All ocular movements were defective, and there was a grade 4 RAPD. And surprisingly, the cornea was relatively clear. Maybe because of the long-standing proptosis, and the lids were stretched and they were covering most of the cornea. The cornea was clear. And MRI showed a few large mass fusiform lesion which was extending into the apex of the orbit, and the optic nerve was not seen separately. There was no calcification or tramp tracking as seen in a meningioma. An axial view showed an extension of 7 millimeters into the intracanalicular portion. So we brought our heads together, and the plan of treatment was do a lateral orbitotomy and excise the mass alone, that is the mass which is optic nerve glioma. So excise the mass of the optic nerve behind the globe, so and preserve the globe like that. So the globe would not go into thysis bulbi because the vessels are coming, the muscles are left intact, and the anterior ciliary vessels will bring the blood supply to the globe. Only the optic nerve is cut from the anterior to the posterior end. So even if you do that, there is no thysis bulbi. So the plan B was, if I could not reach the tumor, plan B was enucleation and then excise the tumor and then put in an implant. If the globe was there, there was no need of implant. So through a lateral orbitotomy, we found that we could not access the tumor at all because it was totally filling the orbit, and we had to do an enucleation. And then you can see that the mass was filling the orbit. There was no, you could not put in any instrument because it was filling the orbit, and you can see under my tenotomy forceps, that is the mass filling the orbit. So even after enucleation, we could not access the posterior aspect of the optic nerve, from where we had to resect the tumor. So it was debulked and suctioned out. It is a very friable mass which was suctioned out, and then the apex of the orbital nerve was cut, and the residual tumor was removed. So later when I went back and saw that there was a paper comparing en bloc resection to resection after evacuation and suction of the orbital contents, and they found that this evacuation and suction of the orbital contents produced a lesser damage to the structures around the annulus of Sinn and the other cranial nerves. So it minimizes the risk of other cranial nerve injury and also to the other optic nerve. When you pull through the chiasm, the other optic nerve also can get injured. So the optic nerve stump was cut. But here what happened was there was an intracanalicular extension, so there was high risk of CSF leak from the cut end of the optic nerve stump. So a neurosurgeon who was just an innocent bystander came to see the case actually. So I was like, and I had consulted many others who had previous experience with this, so they said the CSF leak has to be prevented somehow. So he told me to get a right angle forceps from the GOT, that's a general OT. So they do it routinely for excising pituitary adenomas, it seems. So that was brought from the OT, and so it was very easy to clamp the posterior part of the part of the optic nerve near the optical apex, anterior to the annulus of Sinn, and then non-absorbable sutures were passed under the forceps, and as the forceps were removed, the sutures were tightened so that there is no chance of leak, CSF leak. And an implant was also placed in the orbit, and as a precautionary measure, we gave tab acetazolamide for 3 days. But to our happiness and relief, there was no CSF leak post-operatively, and the biopsy came as pilocytic astrocytoma of the optic nerve. So optic pathway gliomas can be seen in 20% of CNS. That was a slide I wanted to show earlier. Optic pathway gliomas are seen in 20% of CNS tumors, and of these 20% are optic nerve gliomas, and they can be either sporadic or they can be associated with neurofibroma 1. Sporadic optic, as in our case, it was a sporadic optic pathway glioma. It's usually unilateral and there is more risk of visual loss, whereas in neurofibroma associated one, there is lesser amount of visual loss and it can be bilateral or unilateral. So that was a pilocytic astrocytoma, and we fitted him with a custom artificial eye, and he was seen by a tumor board at a referral hospital, and they found that there was intracanalicular thickening, And the implant you can see in place, and they advised repeated MRIs, but no adjuvant chemotherapy or radiotherapy. So he's going to take MRIs every year and see if there is tumor extension, and then do. Thank you.
Thank you, ma'am. Any questions or comments?
You had counseled the parents for education?
Yes.
I request Dr. Marian Poli to present the next talk, Challenges in the Management of Lid Hematomas.
Good afternoon, everyone. Thank AIOS for giving me this opportunity. So, a few challenges in the management of lid hematomas, primarily a case-based discussion. So, coming to the evaluation of lid hematoma, always we have seen most of the time it's post-traumatic hematoma. But in that case, you have to know whether it is accidental trauma or exactly what's the nature of the trauma. You can get a post-op after surgery, then after peribulbar injections, then vascular malformations, then blood dyscrasias, etc. Whatever is the case, you have to evaluate completely. Even though obviously it looks like a lid hematoma, always assess for any optic nerve dysfunction, check the intraocular pressure, ocular motility, and look for lag of ophthalmos. Coming to the investigations, we have to get, if it's a non-traumatic hematoma, you have to get all the coagulation parameters to check and look for any drugs patient is on, and imaging. Management goals primarily to preserve the vision, treat compressive optic neuropathy present, protect the cornea, control the IOP, and prevent any occlusions. So medical management, first of all, ice compresses, systemic steroids if it is a big hematoma, oral serratiopeptidase. If IOP is high, you can give acetazolamide and acusuppressants. So coming to the cases, so case one, first one is a 63-year-old female presented with injury with a wooden stick, right eye. So on examination, there is a total lid hematoma with a mechanical ptosis, but you have to always see the globe. There is a proptosis and the vision is only 6/12. And there is RAPD and motility restrictor. So there is an element of compressive optic neuropathy. In this case, we have to rule out globe rupture also. If there is an element compressive neuropathy, always start the treatment. We can admit. If there's a hematoma, or can start with some hemostatic agents, that is encapsulate, which is the one which we commonly used in our hospital, and stabilize the patient. You can give a first dose of intravenous steroids just to prevent the visual loss, and then send the patient for imaging to see the extent of the bleed. Coming to the second case, this patient is another 35-year-old patient presented with the injury while cutting tiles. So on examination, on external examination, you can see a small lid hematoma with the subconjunctival hemorrhage. So on close examination, otherwise eye is all right, like vision 6/6, pupil normal, fundus normal, ocular motility full. So on a close examination, you can see there is a small laceration here. So this you cannot treat just like a simple hematoma. You have to get the imaging done. So it showed a portion of the tile and needs exploration, and the tile has been removed. So this case highlights the importance of imaging and always ask the nature of the injury. Coming to third case, 25 years, presented with the redness and blurring. On examination, vision 6/12 and 6, pupil RAPD. So there is no history of trauma, so we have to rule out other causes. So it was a case of orbital varix with the bleed. So treated with steroids, since had compressive optic neuropathy, intravenous methylprednisolone, oral steroids, vision improved, and we have taken an opinion from interventional radiologist also. Similar is the case with the lymphangioma. So it presents with a bleed either in the subconjunctival space or in the lid. Get the imaging done and diagnose what exactly is the reason. If there is a compressive optic neuropathy, you can do an immediate canthotomy and inferior cantholysis in the OPD itself to preserve the vision. This is pediatric cases. Sometimes lots of diagnostic dilemmas can come. Acute onset proptosis can be due to either hematoma or a neoplasm. So look at this image. He's a 10-year-old boy. You can see a board-shaped lesion in the superior orbit. So radiologist has given a DD as either neoplasm or subperiosteal hematoma. In pediatric cases, you cannot, very difficult to elicit the trauma history. So we have taken the child under written informed consent. First we aspirated and blood came off, so diagnosed as subperiosteal hematoma. But this is again another case, again similar radiological picture with a vague history of trauma, but this turned out to be rhabdomyosarcoma. So this kind of cases you have to manage with a very caution. Then hematomas associated with the fractures, usually it's like benign. Wait for the hematoma to resolve before embark on the fracture floor after reassessment. So coming to the postoperative lid hematoma, this patient who had undergone an uncomplicated ptosis correction presented to us 1 week following surgery. After a sneeze, he developed a small hematoma involving the upper eyelid. You can see this is a initially managed conservatively. So 1 week you can see some changes on the skin, like skin is going for necrosis, and there's an aesthetic element also because the patient had undergone ptosis correction. So we planned for drainage. All the investigations were within normal limit in the preoperative period. Even though we tried aspiration, again fresh blood was coming up. So I have put a pressure bandage and removed after 5 days, but still it started bleeding. So again managed conservatively. Even at 4 weeks, this was persisting. So like we were thinking what is happening in this young boy that is 18 years. Repeat cauterization and repeat drainage and extensive cauterization was done under general anesthesia, and extensive hematological evaluation was also done. So in this repeat routine blood examination, we found eosinophils were very high. So we had then the other differentials came in, whether it is leukemia, eosinophilic vasculitis, or any abnormalities with coagulation. So we investigated him further with platelet function testing. So in the platelet function testing, he had low aggregation pattern to ADP and collagen or platelet function testing. So in this case, we had eosinophilia and abnormal aggregation pattern on platelet function testing. So he was diagnosed to have acquired platelet dysfunction with eosinophilia syndrome. So this is eosinophilia is a very common condition we see in our practice, but when we do surgery, you can get this kind of picture. It is usually seen in younger age group and self-resolving condition. The mechanism is not clearly known, but eosinophilic cationic protein, that's the basic protein in the eosinophil primary matrix, described as the platelet aggregation inhibitor. So that is why the bleed comes. Coming to the 8th case, again it's a typical lid hematoma presented following road traffic accident after 1 week. So initially conservative management was not resolving fully, and he was getting some skin changes, so he underwent a clot evacuation under local anesthesia, and he did well. So now again 9-month-old child presented to us with a vague history of trauma because from the parents, but in this case there is a lid hematoma and subconjunctival hemorrhage. Here also some bruise is there. Now look at the child, there is an element of anemia. So this is a very dangerous situation. Don't go for MRI first. Get the routine blood and peripheral smear. It was a case of acute myeloid leukemia presenting as scleroma. So lid hematomas, myriad of presentations, always assess the etiology and always ask for the history also. Aim is to preserve the vision, explain the possibility for rebleed in some of the cases. Mostly it will improve with conservative management, surgical management only if indicated, and we'll get a gratifying results. Thank you.
Thank you, Marian. This people with liver dysfunction has, when we give peribulbar block, no, you will get
Hematoma, yeah.
hematoma. Liver, other bleeding clotting time, I mean hematological, we always check, but liver we not check.
Yes.
So thank you, doctor. Any other comments? Thank you very much for that extensive cases. Now we come to the last talk of AIOS 2025, Dr. Vinay Pillai.
Started with the first talk.
You had all the first talk also. Okay.
Alpha and omega.
So
And nothing
he
in
had the
between.
first talk also 4 days back. Okay.
Last show. Thank you, Dr. Basman and KSOS for this opportunity. So each case is a learning opportunity, and this is one case which taught me to say never again for a case. So, 54-year-old female presented with redness in the left eye of 1 week, uncontrolled diabetic, was somewhere around 300s when she presented. Vision was 615 in right eye, best corrected. Left eye 618, right eye was normal, and this was the picture on the first day when she presented. She had a small infiltrate on the infratemporal cornea peripherally with surrounding edema, small defect, AC reaction. So the protocol in such cases is do a corneal scraping and send it for smears, grams, KOH, and cultures. Started fortified cefazolin, tobramycin eye drops hourly with atropine, and was sent to a physician for diabetes control. So, cultures came negative. There was no response to treatment. There was progressive worsening. Because of worsening with thinning, we did a cyanocolate glue BCL, but it kept on worsening, and this was the picture in about 10 days. Okay. Total infiltrate, coagulative necrosis, worsening. By then, her blood sugars were slowly getting under control. But then, with this picture, and there is no point in waiting conservative anymore. It will just melt off, and by probably in 24 to 48 hours, you'll just have the iris presenting if we wait here. So this was the B scan on that day, practically normal. So went ahead with the graft. And now what was surprising is after the peritomy, if you notice that supratemporal area, there was a extension, dense scleral extension with scleral necrosis, which forced me to do a scleral debridement there first, then marked with a large trephine, I think 12 or 12.5, but then no trephination, freehand dissection. The exudate was peeled off. Usually in such graph you get the entire lens coming out, but then it stayed. So the donor was also marked with a 12, but then not punched. Partially the scleral rim was removed along the mark, but then we needed a flange for the sclera to cover the area where the sclera was debrided. So after putting few sutures along the one margin, the other area was hand fashioned to fit the defect and sutured closed. So this was how the patient was in the post-operative period. The graft was edematous. AC had fibrin and heme, but no exudate. And the antibiotics was changed, was put on ceftazidime and vancomycin orally and systemically, along with atropine and Dorzox and other medications to control the pressures. Large graft, 12.5 year meddling with the trab, and these patients invariably will have high IOP post-operatively. So this is how the condition progressed. There was no recurrence of infiltrate or anterior chamber exudate. So in about 2 weeks, the eye started to quieten down. We started her on topical steroids. Now, in 3 weeks post-op, when she came, inaccurate PRPL positive, but then the globe was soft, and this was the B scan. There were, choroidal detachment. So we started her, added oral steroids to the regimen. Luckily, she responded. This was how it was after, after about 4 to 6 weeks of treatment. Eye quietened, graft totally edematous, not much of view of the AC was there, even though we could faintly make out it was formed. Hypotonous globe, B scan normal, 6 millimeter. So, in such situations, well, we know this extensive infection, inflammation, problems, and IOP not building. A possibility is that pre-thysical state, the eye is going into thysis. The situation was explained to the patient, and was nil visual prognosis was explained, and best left alone. After this, the patient was lost to follow-up. Okay, she didn't come back. 6 months later, there was a surprise. The patient came back, still PL and PR was accurate. IUP was 10. The eye was doing well. The graft, of course, was failed edematous, but then AC was formed. Okay, everything was okay. Now I was in dilemma. Okay, should we do anything or not? Luckily for me and for the patient was insistent on doing something. So we went ahead, did an optical penetrating keratoplasty with cataract removal and posterior chamber. Now, optical penetrating, we did a central Ferrumber 8 or 8.5 millimeter, and this was how the patient did. And This is a scan, anterior segment OCT showing, not sure if it is there, yeah. This is the old graft host junction, sclera to sclera, and this is the new graft host junction. And we had follow-up till 2020 where the patient maintained vision of best corrected 6/18. So yes, cases take us by surprise. Well, should we give a good prognosis in all those cases? No, but then probably we should be a little bit more lenient there when we say nil visual prognosis. Thank you.
Thank you, Dr. Vinay. Any comments?
In all cases of corneal ulcer, we can give a thing. We need a second graft.
Sorry?
In all cases of corneal ulcer, when you do a first graft,
Post-therapeutic.
you may need a second graft.
It depends on cases. Okay, it depends on cases and how they do post-operatively. Most of them may not need, especially bacterial ulcers. Fungal is an entirely different entity altogether. In bacterial ulcers, many of them we can manage with the first graft, provided the graft is of good quality and it is not a multi-drug resistant organism, because in about 10 to 15 days we can start steroids. Okay, so many of them have clear grafts.
See, I have one question, why did you wait for so long for the ulcer to become full?
Oh.
Initially, you could have done it
When the non-response was there, we should have done. The reason was patient.
Vinay, was the patient on atropine immediately after the surgery?
Yeah. Always. They are atropinized till 3 weeks.
Hypertrophy is actually because of the surgical cyclodylase. You have taken the sclera off.
Possible.
That area is actually cyclodylase.
Possible. But you do, the graft was only 12 millimeter.
No, but you've taken the scleral spur on one side off.
Yeah.
The necrotic thing.
Yeah, 2 to 3 millimeter.
And you can't obviously suture it back down. So you
Possible.
You'll have a scleral cyclodylase immediately. So atropine will help there.
Yeah,
That's it.
post-therapeutic, all of them are on atropine. 1. 2, in this case, initially the IOP was very high. Probably because of the fibrin and the blood, muck, everything, obstructing the axis of the aqueous. No, she stopped everything. Yeah.
Mostly,
Yeah.
they might have gone for second and third and
That's what I
fourth
said.
opinion.
That is what I said. We cannot, say anything here. Didn't get anything. So most likely gram negative. The way this progress.
It looks like pseudomonas.
Culture, biopsy, everything. Nothing came.
They directly played it on this thing in the theater itself.
Yeah.
Okay, so that was a good session actually. All very good cases with excellent learning points. Unfortunately, last session, but we are happy that AIOS gave one opportunity to state societies. I think for the first time, second
Yes,
time, first time. So we thank AIOS and everyone for remaining here
Yes.
till the end of that. Thank you very much.
And there is small announcement, like if anybody have not received that mementos, because AIOS is giving mementos to all the speakers, so it is still there in the registration counter because scientific office is closed, so you can go and collect it from there. And thank you once again for all the participants.
Thank you.
We'll stay here for a photograph, all.